Okay. All right. Good morning. Can I make you co-host, Amy? Just in case. Sorry, everybody.
I think that I'm a host. Do you need me to,
Uh,
do you want me to to present the screen?
no, I have it. I just
Oh,
was
okay.
see people entering in. That's all.
Oh, gotcha.
Yeah.
Okay. Yeah.
Okay. I'm so sorry. Okay. Anyway, we'll just do it this way. So, good morning. My name is Megan Bettinger. I'm the program manager at Colorado Respite Coalition, and this is our first of 4 meetings we're going to have in 2024. So we have these statewide quarterly meetings, and we have a different subject every time. And so today, again, for the people that have just joined, if you could just enter your information in the chat, and then we can see who's joined us today. So today we're going to talk about regional respite coalitions. Just briefly, our respite coalition is in the process of revamping our statewide respite coalitions. We have a pretty strong one in on the Western Slope, and we would like to model that success and move to around other parts of Colorado. We're specifically looking at the southern border of Colorado, and then the southern area, meaning Pueblo, um, El Paso County, and that area. So there is a Western Slope meeting on March 14th. If anyone is interested in joining that, let me know. We can send you the information to join that meeting. I don't know if there's anyone on here from the Western Slope, but if you are here, you can speak up. Okay, so, okay. Like I said, so sorry. There we go. So the next thing we're going to talk about is the National Strategy to Support Family Caregivers. This was published in 2022. It's from the Administration for Community Living. This is where our federal lifespan grants are awarded from to the state of Colorado. And then Colorado Respite Coalition is the, I guess, fiscal manager of that grant. And so many of the, as I say, we are kind of incorporating or kind of modeling what we're doing in the next few years on this national strategy. So the goals of the national strategy to support family caregivers are increase awareness of and outreach to family caregivers, advance partnership and engagement, strengthen services and supports for family caregivers. Specifically, the outcome family caregivers can obtain respite services that meet their unique needs, and person and family-centered, trauma-informed, and culturally appropriate caregiver services and supports are accessible for all family caregivers. And a range of evidence-based education, counseling, and peer support services are available to family caregivers. Goal 4 is ensure financial and workplace security, and goal 5 is expand data, research, and evidence-based practices. So there's a link if you're interested in reading the national strategy. You can find that right here. I can also send that to you in an email. Okay, so to have a sense of kind of the number of people who may need support services in Colorado, the Bell Policy Center in 2020 published a report So it's estimated that there are about 870,000 unpaid family caregivers, and this is just of older adults in Colorado. This is not of other populations. So by 2030, the number of family caregivers is estimated to be over 1 million unpaid family caregivers. These numbers, again, do not include the many caregivers of people with chronic conditions and intellectual and physical disabilities. So in researching today and also common knowledge, there are numerous caregiver self-care articles and resources that are available online. I think we all kind of know the point of how vital it is for caregivers to make time for this themselves, even though it seems it's an impossible thing to do. And so we want to encourage caregivers to join a support group, go for a walk, have lunch with friends, anything that makes them kind of step away from their duties. So, but I also want to say that we all know that for many caregivers, there are many barriers to having time to themselves, and we acknowledge that, and we know that it's a journey. So, but we're here to support and offer information and direct people in the right to the right people. Anything we can do to kind of alleviate that stress for them. So caregivers self-care suffers because they lack the time and energy to exercise, eat properly, take a break, any of that kind of stuff. They are also likely to skip going to the doctor, taking medicines on time, that kind of thing, just with all of the responsibilities that are before them. So according to the Family Caregiver Alliance, evidence shows that most caregivers are not prepared for their role and provide care with little or no support. At least 1/3 of caregivers continue to provide intense care to others while being in poor health themselves. Research shows that family members who provide care for chronic and disabling conditions are at risk for emotional, mental, and physical health problems. And further, the psychological health of the family caregiver is negatively affected by providing this intense type of care. It is common to have higher levels of stress, anxiety, depression, and other mental health effects. Some estimates show between 40 and 70% of caregivers have clinically significant symptoms of depression, and with 1/4 to 1/2 of these caregivers meeting the diagnostic criteria for major depression. So as the care recipient's condition worsens, there's an increase in depression and perceived burden levels on the caregiver. There are higher levels of clinical depression for caregivers of those with dementia. And some studies show that 30 to 40% of dementia caregivers suffer from depression and emotional stress. Caregivers who are depressed are more likely to have coexisting anxiety disorders, substance abuse, or dependence, and chronic diseases such as diabetes. In addition, caregivers suffer from high levels of stress and frustration and can also feel angry, drained, guilty, and helpless. Caregiving can also result in a loss of self-identity, lower levels of self-esteem, constant worry, and feeling less effective and less in control. Family caregivers are at a greater risk for higher levels of hostility and may have increased alcohol and other substance use and abuse. So evidence reveals that caring for a chronically sick person can have serious physical, mental, and emotional effects on the caregiver. So finally, so we're discussing this today because, of course, it aligns with the national strategy of Goal 3. So and as that national strategy kind of outlines, is that caregiver health and mental health is becoming a public health issue. Given, and especially in Colorado with that big increase, in 7 years, 6 or 7 years, of over 1 million unpaid caregivers in Colorado. Things have to keep up with that. We have to have more focused attention from health professionals, mental health professionals, policymakers, and then as well as caregivers. So several areas can be addressed to help alleviate the negative impact of caregiving. Assess family caregiver needs to develop a care plan with support services, caregiver education and support services, respite, and financial supports. So the following is, so today, actually, sorry, we have two speakers, Brian Talent and Anne, I'm gonna not say your last name correctly. Sorry.
DeZenzo.
Okay. So I'm gonna go ahead and also one of our speakers was not able to join us today so we're due to a personal matter. So we're not going to hear from him. However, he said it was okay to share his presentation with everybody. Okay, so I'm going to introduce Anne. So Anne DeZenzo is a licensed clinical social worker who has been a senior reach therapist with the Access Health Systems since 2017. Anne provides in-home counseling and service planning for individuals, families, and caregivers. Originally from New Jersey, Anne moved to the Southwest region in 1995. She lived in Grants, New Mexico, and moved to Farmington, New Mexico to serve as the director of a community mental health program for individuals with developmental disabilities. During her time off, Anne enjoys traveling, home improvement projects, and spending time with her partner, Tricia. They're now fully grown sons, Benjamin and Caleb, and their two dogs, Oliver and Riley. So, Anne, do you want to present, or should I present for you?
Well, we can see if I can share the screen. Let's.
Okay, I'm going to make you co-host.
Oh, is that how it?
Yeah. Yes.
Okay. Can people see it?
I can't yet.
Let me see. Back it up.
But I have it pulled up if you need it.
Maybe you can stop
Megan, I
presenting
think you
too.
have to stop sharing.
Oh,
Yeah.
thank you.
You bet.
That's probably right.
Okay, now we can see senior reach.
Oh, wonderful.
Okay.
Thank you.
Okay. Well, thank you, Megan.
Sure, you're welcome.
I appreciate having the opportunity to share with you all a little bit about the Senior Reach program. As you said, I've been with Senior Reach since 2017. The program started in 2016. There's myself and Anne-Marie Greenberg, and we're also looking to get... Excuse me? Hello? Can you hear me?
I think that was an accidental
Yeah.
unmute.
Yes.
Yeah, I muted him. Sorry about that.
You can carry on, Dan.
Yeah,
Anne,
sorry
about that.
Do I need to admit this person? So anyway, so myself and Anne-Marie Greenberg, I'm a licensed clinical social worker, as you said, and Anne-Marie has her LMSW, and we're currently looking for a case manager. So if anybody knows of somebody who would like to work with older adults in a case management position, please send them our way. I do want to say a little bit about Access Health System. I don't know if you all know, but we recently moved into a new building, 81,000 square feet. We're now, it's called Durango Integrated Health. It's now housing our medical, our primary care, our dental, the behavioral health, outpatient behavioral health as well, and then our administrative building. Our crisis team and our ATU and our detox is still over by Mercy. And then we do have a program, Pagosa, Archuleta Integrated Health, and Montezuma Integrated Health as well. And now we're also up, we merged recently with another agency, and we're also up in the up in the western slope, up top there. So that's sort of a lot going on for Access right now. As I said, talk to you a little bit about the Senior Reach program. And I will say that when I saw the opportunity to work with older adults, I saw that the position, I was so happy that I was able to be part of this program. I can't, let's see, it's not going to the next, oh, there we go. Okay. So the mission of the Senior Reach program is to support the well-being, independence, and dignity of older adults. Part of it is to educate the community on the unique needs of older adults and then connect them to community resources. One of the things about Senior Reach is that it's trying to get the community members, maybe they're concerned about a family member, or they're concerned about a neighbor or somebody that they know just within the community. And maybe they're not sure what to do. Maybe they feel like, do I need to report this to APS? Do I need to call law enforcement? I just really want to get this older adult some help. What do I do? So that's what the Senior Reach program was created to do, is that people can call. If we hope that they tell the older adult that they're going to refer to the program, but they don't have to. And so they can give me a call or call the hotline, which is 970-335-2217. And they kind of give the presenting issue, maybe a little bit of information, their name, maybe age. The program is designed for people over the age of 60. It is for people living independently. We do follow people to say they need to go into the nursing home for rehab, or maybe they're going to go there for permanent. We can follow them while they're there. And then over time, probably once they're in the nursing home, if we feel that they're stable, we would pull back. But like I said, if people are going in there for rehab, we kind of meet with them, make sure, and then ensure that they get transitioned back into the community and maybe continue to see them. Some of the things we do is we provide individual therapy and care coordination. We do a lot of case management, as you can imagine. Helping people, maybe contacting third parties on their behalf, family, friends, religious organization. We work with the home health agencies, like we work with the single entry point case managers. We work with adult protective services as well. We work with the medical providers and other community resources. We definitely try to get them if they need financial assistance. There's a few areas that we can tap into. We work closely with the La Plata County Senior Center, Meals on Wheels, Home Chore Program, and then our Senior Center currently has a program called the Senior Companion Program. And so they have on staff, paid staff now, that can go and visit with an older adult for about an hour or two every week or every other week. It's a really a great program, especially for those who maybe don't have a lot of contact with people outside of just maybe one or two other folks. I've really liked that program through the Senior Center. So, and then, they kind of coordinate the taxes, doing the taxes right now. I know that's going on with VITA. Some of the other things is we help them connect for food assistance. We help them sign up for long-term care and other paperwork as needed, because I know that a lot of our older adults can be very overwhelmed by that. And then we do consultation we do work with either family members or even work with people who have dementia. I know that for some that can be super scary, and what do I do? Where do I start? And so we're able to sort of help them with that process. So we want to get in there before a serious crisis occurs. And we do find, and it's true, that with the referrals, about 93% of the older adults that we contact accept the services every once in a while, So we have good results, I think, as far as people wanting to participate in the program. It's a nationally recognized evidence-based program. We were collaboration with Jefferson Center for the Mental Health initially, so they also have a program there as well. We find that the Senior Reach has a profound impact in the communities utilizing the program, and has proven highly successful of decreasing depression, anxiety, feelings of hopelessness, and social isolation among seniors. Another thing I'd like to say that we work closely with our core team, which is part of Access, and they go out with the law enforcement, and they just visit not just seniors, but other people in the community. So maybe say I'm concerned about somebody maybe experiencing some suicidal ideation, or just in general, I'm concerned about their anxiety, or that they just need a little point of contact. I can contact our program, and they can go, and they go out after hours, or like they usually start around 10 in the morning, maybe 12. And then they can go there in the evenings for us as well, and kind of check in with people. So that's been a really good program. And now we do it in the county. Initially it started just in Durango, but now it goes outside of the county, into the county. So that's been really great. You know, and of course, even sometimes our lucky rocket ship underpants don't help. So we need to, you know, work, like I said, collaborate with all the area partners. So we, like I said, we try to get in there before a serious crisis helps. It is true. I don't know for you all, but I know out here, a lot of people have come out here from all parts of the country. Maybe their families didn't follow them. I've got a number of people who came out here in the 70s, and, you know, they want to live off the grid, and now they're living off the grid still, but their house is sort of not doing well. You know, they're having lots of problems in that area. Maybe their water system isn't working properly, you know, just little things like that. So we help problem solve those things as well. As you know, for generally speaking, they say that depression is not a normal part of aging. So research shows that seniors are responsive to treatment as other adults are. And as I said, we connect them to many of the services in the community to help improve the quality of their life. So we train community partners. We did more presentations before the pandemic. The pandemic really kind of hit hard. I will say that our program, we were only sort of sidelined for about a month or so, because we needed to get in there. You know, there were a lot of people not being seen because of the pandemic, right? The caregivers disappeared. That was terrible. It was really, and they were being much more isolated. So we were able to go out there and kind of meet with them, even, you know, masked up in the whole thing, but we continued to see them through the pandemic, which I thought was super important. You know, so yeah, so like I said, community partners, the neighbors, librarians, hairstylists, clergy, postal carriers, bankers, anybody in the community can refer somebody to the program. Maybe you're noticing a change in their appearance. Maybe I've had people referred to the program because of a loss of a pet, loss of a spouse, death of a child. Maybe they're more depressed or anxious than normal. Yeah, as I said, their home's in need of repair, trash, debris in the yard, concerns for their pet, showing the signs of a mild cognitive impairment. I find for some people, you know, I think always, and maybe you guys experience this, people hear dementia, they automatically assume the worst. And we're able to say, you know, it's not so bad. We just got to put these things in place and sort of help them put those things into place, so that they can just manage. Make it a little bit easier for them to stay in their home. And as you guys know, I get all the time, I don't want to go into a nursing home. I don't, you know, so that's the goal of the program, is to help people stay in their home for as long as possible. So let's see, anything else? Yeah, so we talked about that. Burden to others, I do get that a lot. That generation, the silent generation, and the baby boomers too as well, they're not used to asking for help. They've been doing it all along on their own. So they really don't like the idea of even their adult children, they don't want to bother them. So trying to encourage them to access those resources, to use, to, you know, get the help that they need. So yeah, there's stigma for seeking assistance. I do find, though, people are becoming much more open to getting the assistance they need. And seeing as we're doing respite, yeah, respite has definitely been a challenge. As I was saying before with the pandemic, the home health workers, when they disappeared, and now it's been a real struggle to replace them. So sometimes we look at different ways. Like I said, the senior companion, is it somebody who just needs a little bit of help? You know, somebody to come by and check on them. Do we get them involved in long-term care? Of course, the waiting list for a caregiver can be up to a year. Then can we provide the support for a while until we can get somebody into the home? Do they have the financial resources to use some of the home health providers? Or can we maybe get them connected with care.com if they have a little bit of financial resources, because at least care.com, it's a little bit cheaper. And, you know, you can kind of see the bios and have a conversation with the people. So we do that as well. And then the financial exploitation, I have to tell you, that's definitely been coming up lately for us. And it's a real challenge. Of course, we tap into APS and law enforcement if necessary. But that can be a real struggle because, as you know, like with the scamming online, I see that all the time, have had to go in and clean up messes in that respect. You know, all of a sudden, you know, maybe I'm helping them with their finances and I'm looking at their and their sheet and their credit card statement, and all of a sudden I see a monthly payment for something and I'm like, what is that? You know, so we're able to go in there and sort of help them, you know, call the credit card company, cancel that if it's not appropriate, different things like that. Some of those things we do as well. So anyway, so as I said before, anybody can call the Senior Reach referral line, 970-335-2217, presenting issues. What do they feel they need some help with? Then we give them a call, see if we can set up a time. Oh, I should say, currently there's no cost to the older adult. We do bill their health insurance, their Medicare, Medicaid, you know, their private insurance. If they can't pay, that's not a problem at this stage. So it's always available, because I know that sometimes our seniors worry about that, or older adults, that they, how much is this going to cost me? So there's no charge. Go in, do an assessment, first appointment. They're not enrolled. It's after that we enroll them if they're interested in the program. Does anybody have any questions?
Thank you. And we do have one question that I just saw in the chat that I wanted to read out. It says, do you serve San Juan County? And if so, are there in-person services available, or do they have to travel to Durango?
We do serve San Juan County, and no, we would go out there. I don't get a lot of referrals for San Juan County, but we definitely have gone out to San Juan County and assisted people. So yes.
Thank you. And then a follow-up question on that from me is, in terms of the therapy services that are offered through the Senior Reach program, are those offered only in person, or can they also be offered virtually?
Oh, we could do virtual. I will be honest with you. I find our older adults, it's a little bit more challenging sometimes with the virtual, but definitely if they do. And we have a team at Access that will actually help them set it up. So if that's something they're interested in, totally. Yeah, we can have that team go and they'll help set it up on their phone, their tablet, whatever they have, do a test run, and then we can set that up too for that as well. Yeah.
Thank you. Thanks for answering that question. I do think it does make a difference too, in person versus virtual therapy works quite well for lots of people. But there is something to be said for in-person contact, especially if you don't have that familiarity with technology. So I have some more questions, and anyone else too. Of course, this is the Q&A portion of the presentation from Anne representing Senior Reach in Durango. See, she even has a Q&A slide. But I'm just going to kind of prime the pump here with some questions.
Sure.
Since we're focusing on, through the Colorado Respite Coalition, we have a big focus on supporting caregivers specifically. So I wonder if you can talk a little bit more about, it sounds like you're able to help the older adults, which will help the caregiver of that older adult. But I wonder how much you end up helping older caregivers. There are so many older caregivers who, you know, they might be spouses taking care of spouses, or even grandparents raising grandchildren could potentially, I don't know if that's an audience that you have much interaction with, but if you're able to speak to your caregiver support, or if you, in your process in contacting the older adult and getting them hooked up with different community resources, if you, as part of your process, include the caregiver or ask about, do you have, you know, someone who takes care of you, so that you can involve them in the whole process.
For sure. So sometimes I get referrals. It's somebody who has Alzheimer's, but when I get in there, I realize that for me, the client would be, the patient would be the caregiver. Not because the older adult who has Alzheimer's really can't engage and talk therapy and what have you. And then that's, go in, process what's the challenges are, try to come up with some solutions to those challenges. Sometimes it's about they just want to make sure they're doing the right thing. You know what I mean? People do things and they're like, I don't know if that was the right thing to do, kind of thing. So able to process that with them. Generally, we can't meet with people weekly, but we definitely usually every 2 weeks and every 3 weeks, once a month. It just depends on what the person needs. So yeah, so sometimes it is just about getting connected with the caregiver. Now, maybe they don't want to fully enroll in the program, but we can be a consultation. Like, yeah, so I meet with the person. They have a few questions that they need answers to, or maybe they need a little bit of paperwork. So maybe they don't formally enroll in the program, but we're still able to provide that support where I could help assist with the paperwork, or maybe give them some of the resources that they need. Like something I kind of do sometimes is I might recommend palliative care if they can and they're not thinking about it, you know what I mean? They're like, people think hospice, but then they think palliative care is like hospice, and they think that that's long term. You know what I mean? They think, oh my God, well, they're not dying. And it's like, no, I know they're not dying, but this way you get more support in the home. You don't have to take them to the medical appointments all the time. You can actually have a nurse who can come in and do some prescribing, and they don't even realize that that's available to them. So kind of doing a lot of that for older adults. And then, yeah, like talking about the caregivers, like I said, can they get additional support? I use Area Agency on Aging all the time for vouchers. And also they do have the respite vouchers too. Of course, the struggle for that sometimes is that they have to find somebody to be the respite provider. So that can be sometimes the challenge. And then kind of helping them process that. Is there a family members? Do you have a friend who might be willing to provide that support? So yeah, so we do a lot of support for the caregiver as well. And that's what's nice about being able to go into the home. Sometimes you can assess the home. I remember one time I went into a woman's home who had Alzheimer's, and she was living by herself. The family was very supportive and she was doing okay. But I come in and the TV stand is completely knocked over and all, and then I'm like, oh, what the heck? And I looked and one of the legs got kicked out. And I'm just saying, so I can talk to the family and say, hey, can you do a little decluttering? Hey, can we do make the environment a little bit more accessible for the older adults, since they are going to be there and they do seem like they're okay there. So just a lot of that brainstorming, able to provide that. And then, like you say, you guys were talking about before, which I think is, are you taking care of yourself? Are you getting out with your girlfriend or your, whoever, your friend, and having lunch? Are you going for that walk, taking care of your dog? Are you doing stuff, what kind of self-care are you doing? So those types of things. Also, even med management, I do discuss people's medications with them. That's the one area I think is sort of a challenge for older adults with dementia and Alzheimer's, is I don't feel we have enough psychiatrists who really kind of understand, what the proper medications might be for an older adult who has Alzheimer's or dementia and is displaying some maybe challenging behaviors. So that's another thing, though, that I'll consult with family members around all the time. We even help with guardianship. If somebody, it seems like maybe, not that we do it, but we give them the resources for guardianship to kind of obtain guardianship, or what the process is and how to go through that. Conservatorship, also setting up a trust. Sometimes people, to get long-term care, they need to set up a trust. So we do a lot of that consultation, kind of brainstorming with the family.
Wow, I mean, you really kind of do it all. Is what it sounds like, which is really amazing. And it's the approach really is that if you want to support caregiver mental health, then you need to support caregivers in their duties. That's really what the line of reasoning is. What it sounds like to me is that you can tell a caregiver till you're blue in the face, make sure you eat a vegetable and take a 10-minute walk today. And they're like, okay, yeah, well, I would, but I don't really feel like I'm empowered to do that because I have to do A, B, C, D, E.
Mm-hmm.
And now there's an emergency. And now I'm spending time at the hospital all day with my loved one because they had a fall or, whatever it is. So it just makes a terrific amount of sense to have it be the approach is really holistic care of the individual, both the older adult who's needing the support and the caregiver of that older adult. Let's see, does anyone else have any other questions? And we can have more time later as we move through the other presentations if more questions come up specifically for Anne, but Just want to kind of open it up and see. Megan, do you have questions?
I
I saw
do.
you
I
come
do
off
have a
mute.
question. One of my, I was just, and forgive me if you already said this. Do do people that you're referred to are only members of Access Health System, or do you
Oh,
does
no,
out
like
to?
Mercy, now known
Oh,
as Common Spirit, they'll refer people to us. APS
okay.
will refer people to us. Community Connections will refer people to us. So that's it. It's just, it's more like, yeah, we want the referrals from the community, not so much internally. I'm not gonna lie though, unfortunately, because of the nature of the beast. And I think sometimes for us, it's like, oh, you guys work with seniors, let's, at Access, they just refer. But what we really want is the people who are less likely to come into the clinic. So if the person's going to come into the clinic, they come in already for other things, then let's have them see one of the, the MHOP clinicians. But if they're not going to come in, they're like, yeah, they're really, and they're not doing well. Those are the people that we're really looking for, are those that are the most socially isolated and less likely to come in and get help.
Well, thank you very much for that.
Thank you.
Do you have time to stick around and
Oh, yeah, I was going to
questions
hang.
come up at the end, or?
Yeah, I was going to hang.
Okay,
I'm going to,
great.
thank you. I'm going to stop sharing my screen now.
Okay.
There we go.
Okay. Okay, well, I'm going to introduce Brian Talent. You are co-host as well, Brian. So Brian Talent is a licensed professional counselor and associate director at Rocky Mountain Human Services in Denver. Brian has been a counselor and administrator in the community mental health field for close to 30 years. Brian is a contributing member of the National Child Traumatic Stress Network, and he serves on the board of directors of NADD, an association for individuals with developmental disabilities and mental health needs. Brian conducts workshops nationally and internationally on adaptive mental health treatments and resilience planning for people experiencing secondary trauma stress in the helping professions. Welcome, Brian.
Thanks, Megan. Thanks. Good morning, everybody. Just want to start off by saying, Anne, what a fantastic program. Just really cool to hear all of the things that you're doing and meeting the needs, because you guys are really meeting some very important needs that other systems don't really cover or don't do well. So it's just really exciting.
Thank you, Brian.
Yeah, and at some point we should get together too and have a little Hatch green chili, because my wife, who's from Albuquerque, we spend a lot of time down there, and so anyway,
I love New Mexico.
yeah, it's some of the best food and best scenery in the country. So anyway, yeah, just wanted to introduce, well, start off, I guess, by saying, since we're talking a little generally at some point about mental health for people with developmental disabilities, I want to kind of tell folks a little bit about my background. Not that I like talking about myself. I just wanted to give some perspective as to where, how my journey has led me to where I'm at with the Denver START program at Rocky Mountain Human Services. Back in the mid 90s, I worked in the early 90s, I worked at a community center board in Central Illinois as a behavioral specialist. And that was before there was such a thing as a BCBA, or a board certified behavior analyst. That credential didn't exist at the time. I was grossly underqualified and undertrained to be writing behavior programs for people with intellectual and developmental disabilities. I got my counseling degree. I'm a licensed professional counselor. And when I came to Colorado, I was looking for a job, and people said, the Aurora Mental Health Center is developing these programs for people with intellectual and developmental disabilities. And honestly, it was so difficult. The experience that I had in Illinois, I was kind of reluctant. But I really needed the job and needed the money, and I signed on to these new programs that they were developing over at Aurora Mental Health, and I stayed there for 25 years. And I'm very happy to say that it was exciting to be developing and working on specialized mental health programs for people with IDD. And along the way, we had a wonderfully mutually beneficial relationship with the National Child Traumatic Stress Network, where we got a federal grant and they taught us evidence-based practice on treating trauma for people with for treating trauma in children. And then in turn, we taught them how to adapt it for treating trauma in children with intellectual developmental disabilities. And so I can speak to some of the really cool projects and products that are coming out of the National Center for Child Traumatic Stress on supporting kids in particular who have experienced trauma, who have intellectual developmental disabilities. Along the way, too, I met a wonderful, I also served on the board of directors of the National Association for the Dually Diagnosed and NADD. And that is where I met a wonderful psychologist by the name of Dr. Joan Beasley. And Dr. Joan Beasley was part of a handful of mental health professionals who specialized in adapting mental health treatment for people with intellectual developmental disabilities. And Dr. Joan Beasley felt very strongly that if we're going to take this rare specialization in the intersection of mental health and developmental disabilities, then let's take it to the people who need it the most, where they need it the most, when they need it the most, and that's people that are experiencing mental health crisis. I think that we have acknowledged for many years that the behavioral health and mental health provider system does not interface with the intellectual developmental disability support systems and provider systems. And so when people have multiple conditions, they have mental health conditions in addition to their disabilities, they get the whole, you need to go over here, no, you need to go over here, you need to go over here, and the systems argue to the point where people, I used to say fall through the cracks, but they don't fall through the cracks, they slip through fingers. That's the truth. And when that happens, obviously, when somebody has those systemic barriers and those siloed systems have caused people with a dual diagnosis to be untreated, underdiagnosed, and don't have access to good preventative care. And when you don't get access to good routine preventative mental health care, people's conditions deteriorate to the point of being in crisis. So our community is not different than many communities across North America where people with IDD don't get good access to preventative care. And the ending result is people experiencing mental health crisis that not only is incredibly difficult for the individual experiencing those mental health conditions, but their caregivers. And the crisis is not just with the person, but also with their families, their caregivers, and also with their extended service providers. They're also in crisis around the issue of not getting good behavioral health care. So Dr. Joan Beasley created the National Center for START Services, which is based out of the University of New Hampshire. Her goal is not to just be a provider network for people providing mental health support for folks with IDD, but they're also a research facility. The START model, which has been in development since Joan Beasley created this network in the early 90s, it's all evidence supported. So there's research that we contribute. I'll tell you a little bit more about our particular program, but we contribute data that goes back to the University of New Hampshire, who refines our model, who constantly uses real data in order to not just drive our local programs, but also to help support what has been lacking for years, which is research in mental health for people with IDD. And so it's the START model is a tertiary model, in that the idea is that we engage with individuals that are in a mental health crisis and immediately work on crisis stabilization, but then work in order to help people not only achieve crisis stabilization, but ultimately be reliant on their own natural and community supports. And also to develop capacity within the community, and I'll speak a little bit more about that. But that's the tertiary model, where we're working on primary interventions to support individuals, but then we're also working to bolster the community so that ultimately communities can be independent and sufficient with capacity and competency in mental health for people with IDD. So we're constantly trying to put ourselves out of business. And so I want to talk a little bit about our current, and I want to say that, I've watched the START network grow into multiple states across the United States. I think there's some form of START services being provided in around 27 different states. There's only about 5 or 6 certified programs within the United States. But we've been watching that network grow over the years, and there's been multiple advocates, primarily the ARCs of Colorado, our university affiliated partners with JFK Partners. There have been lots of advocates that we have been wanting to bring START services to Colorado for many years. And we have been unsuccessful in getting the state to invest in a statewide program. There's a lot of barriers. I'm not going to get into the details about it, but basically, investing in an out-of-state company to provide a statewide program when the belief is that we can do that organically within the state. My question is, why haven't we been able to do it organically within the state? These are significant barriers. They're not just in Colorado, but all across the United States. But basically, as we've been advocating for bringing START as a statewide model, as a statewide program, the city of Denver finally said, look, we're tired of waiting on the state. We are spending a fortune sending police and EMTs out to mental health crisis situations for people with IDD who admittingly don't know how to handle those situations. They have potential to do harm in those situations. And even in a best case scenario, are basically a taxi service for people to go to the emergency room where they get no continuity of care between their providers in the community and the crisis responders and the emergency departments. So people ultimately, and in many cases now, it's actually, the situation is worse than it's been in the last 30 years I've been in Colorado. But hospitals won't even admit people who have intellectual and developmental disabilities when they're experiencing a mental health crisis. It's a situation that's gotten worse over the years, not better. And so people get returned to their homes with no intervention. And again, even sometimes the basic thing that happens is people get another medication added or a higher dosage increase that is not effective, and in many cases is detrimental. And just contributes to the executive functioning problem of people with intellectual and developmental disabilities, which further hinders their ability to do things like recover from trauma and to manage their mental health symptomology. So what we do at the START program, or what START programs do, is I'll try not to get ahead of myself because I've got some slides and talk about the referral criteria and that sort of thing. But really what we do is when somebody is referred to Denver START, we do a very brief screening in order to determine if people are eligible or not. And like I said, I'll get into the details about that. But within about 24 hours, we make a screening determination of whether a person is eligible. And when they are eligible, we have 72 hours to meet with them in person and to begin what is a very comprehensive biopsychosocial assessment. We know that in our industry that we're over reliant on psychiatry for people who have mental health conditions, who have IDD. And I feel that we're also over reliant on just applied behavior analysis. I think that we are, in some cases, just minimizing people down to a set of behaviors instead of taking holistically at the individual and their happiness. Because as I talk a little bit about the START model, our belief is not just that mental health is an absence of symptomology. It's a flourishing of all the positive things that are going on in people's lives. And so I'll talk a little bit about the positive psychology model that we're rooted in. But we start a very detailed biopsychosocial assessment. And our goal is to do this to support caregivers so that they don't have to be the ones who are documenting and recording all of the strength-based and opportunities and strengths that a person has. We come in and we take a look at what are their medical conditions, what is their medical history, what is their treatment history, what is their social history, what do their environments look like, what is the quality of the relationships that they have, what are the strengths that this person possesses, what are the opportunities that they have, what resources have they accessed, what resources have they not accessed. And that assessment, which typically takes us about 30 days to complete, turns into what we call our cross systems crisis prevention and intervention plan. And that is a very, again, holistic, positive psychology rooted crisis intervention plan and prevention plan where we share that with everybody's providers. And again, it's very person-centered, culturally sensitive. And we that plan is then developed and shared with providers so that providers can then input to the plan, as well as learn about the other disciplines and the other strengths that the person possesses in their life and opportunities so we can build upon them. And then we continue to develop that cross-systems crisis prevention and intervention plan until the person achieves crisis stability. We try to build and link people with resources and services, and then use our expertise in mental health and development disabilities to support the providers. So we're not actually the behavioral health provider. What we're doing is we're linking people with quality behavioral health services, and then we're serving as consultants for those behavioral health providers to understand how to effectively work with people who have an intellectual disability, but also in particular, how to work with this individual and their strengths. We're constantly debunking the myth in the community that people with IDD is a very small subculture within our community, when actuality, it's a very diverse group of people who live in our communities. And so again, teaching them not just how to work with somebody who has an IDD, but also how to work with this particular individual. And the average length of involvement of a person in the START program is about 18 months. So again, our goal is not to be a component within service delivery of people's lives. Our goal is to get them the people and the connections that they need, get those providers the expertise that they need, and then get out. And so that's the model. Now I'll come back to some of these things, but we do that clinical evaluation. We also have a therapeutic coaching team. So when our social workers are out working with an individual and they recognize that they need a particular tool or a set of skills in order to be successful implementing their plan, then we can send out therapeutic coaches to work intensely with the individual, their systems, for about 6 to 8 weeks, maybe about 2 or 3 different coaching sessions a week. And we can do intensive therapeutic coaching while we're still developing. And those coaches don't just go out and provide the skill development. They also are investigators. I mean, they're constantly looking for what are the strengths and what are the opportunities, and bringing it back to enhance the plan for the individual and hone that plan. But probably one of the most important things that we do is we provide an alternative for individuals and their families to calling 911 when they're experiencing a crisis. So what we do is, on the very first encounter with an individual, we leave them with a provisional crisis plan, and we also leave them with our 24-hour crisis line phone number that they can call when they're experiencing an emergency. Now, we don't give out that crisis number to the community at large, because again, our goal is not to be an alternative to existing crisis services. But I say in our community, what we're trying to do is engage with those individuals that need our support so that they are not calling 911, they're not calling EMTs and police to show up to those situations. Instead, we show up in person with their individualized crisis intervention plan in hand. And I have to say that the feedback that we have gotten from caregivers and providers is that they're so grateful that they have an alternative to calling 911 in those situations. And so I'm sort of blessed almost daily with the compassion satisfaction that I get from people saying, wow, we're really just we're really just so grateful. I mean, in tears, that they've got an alternative to going through that experience, which many of them have gone through time and time again. And as a matter of fact, when I knew that again, I've been very connected with folks in the community who provide mental health supports for people with IDD. When I heard that Rocky Mountain Human Services had bid for the contract with the city of Denver to create a START program, I had to leave my employer of 25 years and come be a part of it, because I think it's such an incredibly important service that people desperately need in Colorado. And the START model, I think, is absolutely by far the most evidence-based and supported program that there exists in North America to fill that need. So the third and final thing that we do, not only are we trying to develop these highly supported multidisciplinary teams around each individual and providing that crisis intervention. But the third thing is that we really want to do outreach training and community capacity building. And we do that as a part of the START model. So what we want to do is not just support the individuals, but we want to support the systems within our community so that they understand. And we could talk more about this if people are interested. But one of the main things that we're trying to do at START is to help the behavioral health providers community, as well as the IDD service provider community, to understand this concept of diagnostic overshadowing. I mean, the reason that, and I can explain it briefly, is that the reason that our services have been siloed and the reason that there are access problems for people getting good behavioral health care is because there's a phenomenon that happens, and this initially was thought of as a clinical phenomenon, that in a mental health assessment, a clinician will over attribute mental health symptomology to a person's disability and just say, well, that's just autism, or well, that's just Jane, or that's Billy, when the reality is that no, it's mental health symptomology and it warrants treatment and support. So in order for people to really understand this phenomenon and how to work against it, you have to have an understanding of a healthy person with a disability, which is kind of an oxymoron in a lot of ways in many of our communities, who say, well, how can you be healthy and have a disability? That doesn't make any sense. And so that's our responsibility, is to help the mental health providers understand that no, there's nothing indicative to a disability that causes people to be in emotional and behavioral distress. Those are not indicative. And then also, it's been very interesting as I've moved from 25 years at Aurora Mental Health, and now I'm at the largest CCB in Colorado. I'm surprised at how the IDD service industry, as well as just the caregivers in our community, do the same thing, where they say, well, that's just autism, or that's just their disability, when we're coming in and saying, no, that is a mental health symptomology, and here's how we can support you as well as your providers in understanding how to go about the best course of treatment, and not just ABA, or not just overutilization of psychiatry, but how do we build in something called PERMA in people's lives, which is in a minute I'll talk about. That's the positive psychology that our program is rooted in. So I just would say our anticipated benefits is to reduce the use of emergency services in state facility and hospital stays. We want to help develop cost-effective service delivery across our community systems. We want increased community involvement and in understanding mental health, good mental health for people with IDD. We want to strengthen linkages that enrich the systems and increase resources and fill gaps. So one of the things that we do in our model is we form formal linkage agreements with provider organizations, where we define how we're going to work collaboratively in order to increase access and quality of care, accountability around that quality of care. And we literally write those things out so that we can form those linkages and develop a system of care within our community. But basically our goal is overall higher rates of quality of life and satisfaction for the people that we work with. And again, we feel very strongly that it has to be rooted in a good biopsychosocial model. We know that about behavioral health care, period, that it's kind of funny. What turns out what's good for people with IDD is good for the general population. You know what I mean? And so our IDD, I'm sorry, our behavioral health service provider should be taking a biopsychosocial approach. What we stress is that it's absolutely necessary for people with IDD. If you don't take the biopsychosocial approach, we will end up doing harm, which is our greatest ethical obligation, is to do no harm. So the biopsychosocial model is something that we're very embedded in. And we're trying to help our community understand how to best go about that, because that's really the components that interact in order to bring overall general health and happiness. Because PERMA is really what it's all about. It's about the 5 qualities that make up general well-being and happiness, and that's positive emotions, engagement, relationships, meaning, and achievement. And that is the undercurrent in everything that we do at Denver Start. So what does our program look like? And right now we are, and again, this was the city of Denver, through their IDEAS program, which is the mill levy funds, tax funds that are earmarked for people with intellectual and developmental disabilities in Denver. They fund our program. We have been in operation for about a year and a half. So we started our public launch in September of 2022. And I can tell you a little bit more about sort of where we're at as a program, but this is what our team looks like. We have a program director, which is myself, which is primarily an administrative director. We have a clinical director who's a licensed psychologist, and their position is to basically maintain the clinical integrity of the program, and making sure that we're implementing the model to fidelity. We have a medical director, which is the most wonderful luxury. I mean, it's a luxury from where I've come from. But we have basically 10 hours a week of medical consultation from a licensed psychiatrist. So we have a medical director who looks over everybody's medical conditions, their medications. They provide medical consultation to our START coordinators, and they can provide consultation to the providers in the community. So they can do physician consult, and again, provide that support, especially around their knowledge of people with intellectual and developmental disabilities. And then we have a clinical team lead over our coordinators. We have a clinical team lead over our coaching team. But the START coordinators are the heart of the program. These are typically master's level clinicians who are cross-trained in developmental disabilities and mental health. They, as soon as a START coordinator is hired onto the START team, they enter into a 20-week certification program, which is basically a course put out by the University of New Hampshire that cross-trains people in developmental disabilities and mental health. And so we have 6 START coordinators, and they're the ones who not only do the assessments and the crisis planning and prevention planning, but they also provide the 24-hour crisis response support. So they go out 24 hours a day and respond in person, providing that crisis support. And then we have 3 therapeutic coaches. We have an opening for a therapeutic coaching position. These are typically bachelor's level folks who go out and again, not only teach those skills, but are fantastic investigators in that they bring back wonderful knowledge to help hone an individual's crisis plan. And then we have a program administrative assistant who helps support us with data processing, finances, and other supports. So here's the Denver Start eligibility criteria. We serve people ages 6 through the lifespan. Probably the most complicated piece of our screening process is that people do have to meet the state IDD eligibility criteria, which some of you may intimately understand. Some of you may not know at all what that means. I have to say that very early on in our program, and still even today, we get a lot of referrals for people who are not eligible because they simply don't meet the state IDD criteria, which is mostly about, people having evidence that they had their disability within the developmental period before the age of 22. They do need to have another mental health need or behavioral health challenge, but that's probably the most open, in that we understand that most people don't carry a clinical diagnosis. They've never been properly assessed. So that's probably the most open-ended part. You probably, as a supporter of a person with a developmental disability, understand that there's not anything indicative to behavioral and emotional dysregulation. And when that happens, the person needs the proper supports. And the last that I don't have, I'm not sure why it's not on this slide, is that people currently right now do need to be a resident of Denver to access our services. They have to reside within the Denver city limits. I want to say, and I can talk a little bit about the program development. Our goal ultimately is for this to be a statewide program. What's happening right now is the county of Boulder has expressed interest in expanding our program to be extended out into the Boulder community and Arapahoe County because of the high numbers of foster homes, host homes, and group homes, as well as individuals who just live in Arapahoe County. we're also looking to expand into Arapahoe County, probably around halfway through the year of 2025. Right now, we're working on program certification with the National Center for START Services. We hope to be certified and be able to demonstrate that we've successfully implemented this model to fidelity by the end of August of this year. So our sights are set right now on certification. We're doing a no cost or low cost extension of our contract with the city of Denver, probably till about June of 2025. And when we renegotiate that contract, then we'll be talking about adding other communities to our provider network. Just one caveat, that this is not too important, except for in rare cases where the city of people have to be a resident of Denver. The one little exception are children that are in the custody of Denver Department of Human Services. They're considered Denver residents regardless of where they live. But we had to draw a border basically around the Denver metro area to say, this is where we can effectively provide crisis services for kids that are in custody of Denver DHS. Because they could be placed as far north as, Fort Collins, or as far south as Pueblo, or out on the western slope. And so we had to say, even though they're residents of Denver, this is realistically where we can provide crisis services to those children. Hope that makes sense. So community networking is a huge part of what we do. We have an advisory council I can speak to. We do consultation with behavioral health as well as IDD providers. Every month we do a clinical education team training, which is part of the START model, where we partner with other organizations in the city of Denver, and we basically do a case presentation. We select a case and a unique quality about that case, or an important, significant quality to that case. And then we not only do we do a case study, but we do a didactic clinical training on that aspect of the case that's very relevant. And we do that for community partners free of charge every month, because our goal is to get input and resources from the community to help us support that individual. So we do that every month. And again, our goal is to partner with large organizations like Denver Health, with the co-responder police program and the STAR program. Our goal is to partner with large organizations like WellPower, our biggest community mental health center, and do these clinical education teams with them and their staff, so that we can really have a forum to take a deep dive into these individuals' cases and the aspects that are unique about those cases. And then every single individual that we support has cross-systems crisis prevention and intervention meetings. This is where we pull in all of their providers. Our goal is to provide the care coordination so that caregivers don't have to. One of the things I just want to stress to this group is that I totally get it. Sometimes you want to say things like your experience is, I've got 9 professionals involved in this case. Why do I need 10? You know what I mean? I totally understand that sentiment. But one of the things that I want to stress about that is that you may have 9 providers as a part of your support network, but how many of them will show up at 2 o'clock in the morning when you're experiencing a mental health crisis? And typically the answer to that is none. And the other part is that we really want to provide that care coordination with our expertise in mental health and development disabilities, so that caregivers don't have to do that part. Again, and our goal is to be highly culturally sensitive and very person-centered in the way that we develop these plans, so that you don't have somebody who comes in and upsets the apple cart. Because that's sometimes the apprehension too, is like, look, we're only having 10 crises a year, and that's crisis stabilization from our perspective. And our goal is to say, and don't come in here with your expertise and disrupt things. So we're very sensitive to those concerns. And our goal is not to come in and take over. Our goal is to come in and provide advocacy that is very person-centered and culturally sensitive, and to help guide the other providers in understanding that. And again, our entire model and our forms and everything are completely around that idea of PERMA. So we do have an advisory council. The process is very informal. People are welcome to join our advisory council. It's currently made up of about 25 or 30 organizations across the city of Denver who have a vested interest in our outcomes. We meet quarterly. Our goal is to report our outcomes out to the advisory council, and then to get guidance and information and resources back. It's not a governing council. It really is just an advisory council and is relatively informal, but it's very powerful in the way that it guides our program. And it's made up of people with lived experience, which are first and foremost the best and most important aspect of our advisory council. We have family members of service utilizers, regional state leadership, organization leaders, service providers, and all of our linkage partners are invited to be a part of our advisory council. I think I've talked about the clinical education teams. Basically, it's a part of the START model. It happens they're monthly. They last 90 minutes. And again, we sort of started out by just opening it up to the community. And I think as a program, we're now starting to try and use our clinical education teams to form more linkage agreements with partners in which we share clients to say, let's do a deep dive in a deep clinical understanding and holistic understanding of this person. So if you have referrals for the program, here's our website, our email, our phone. You can contact us anyway. I would love to, in a minute, drop our flyers into the chat if that's okay, because I'd love for people to have our flyers. You can always email us at start@rmhumanservices.org with any questions that you have. It's not unusual for people to have questions about a referral. They say, I think I have somebody we would love to refer to your program, but we're not sure if they meet your eligibility criteria. And so please contact us and we'll walk you through that. We will see what information that you have on the individual. Or if you are an individual, we can help look and see what records and assessments and things, provide education around what the IDD eligibility criteria is. We can serve individuals who have not entered into that eligibility process. If we see in the screening that this person is going to meet IDD state criteria, then we can start serving them provisionally and enter them into that process, you see, and support them as they go through the IDD eligibility process. Sometimes, honestly, it's just too close to call. Or we may look at the screening information and say, there's no way this person is going to be eligible. And in those cases, we work internally at Rocky Mountain Human Services to link them either to our intake department at the CCB to say, let's fast track this individual, get a determination so that we can find out whether or not we can serve them. And if we can't serve them through START, then we hand a warm handoff to our single entry point, which is the state program that helps us. People may be eligible for a TBI waiver, or they may be eligible for a mental health waiver. There's lots of other state waiver programs that they may be eligible for if they don't meet that criteria for a DD waiver. So it's helpful when making a referral that you have the basic demographic information on the person, that we have the referral information for the person making the referral. It always helps us to know who are the caregivers involved and especially guardianship status. And then if you've got diagnostic information and documentation, that's always helpful, but it's not totally necessary. Like I said, we'll work with you on the screening process to understand kind of what would be the course of that we would take after that screening. Would we immediately, assign them to a START coordinator, or would we work internally at RMHS to get them the right resources? Okay, so that's a lot. I feel like I really talked at you all for like a long time there, and I threw all kinds of stuff at you, and I want to stop talking now and open it up for questions that people might have about Denver START, or just behavioral health for people with IDD in general, or the diagnostic overshadowing that I mentioned. And with that, I'll stop talking.
Brian, there is one question in the chat. Does this person have to receive their case management services from RMHS? They
do not. We serve multiple individuals who reside in the city of Denver who get their case management services from other CCBs. So the eligibility is not about where their case management comes from. It really is about residency and whether or not you are a resident of the city of Denver currently. Great question.
Thank you.
Is there anything else I missed in the chat? I always miss things in the chat when I'm rambling.
Well, one question is, can we share the slides?
Yes,
Okay,
absolutely. I'll be happy to I can actually even drop it in the chat also.
oh, okay, thank
But
you.
and to make it available, if Megan, if I could get it to you for distribution, would that work okay too?
Absolutely.
Okay.
Yep, thank you.
Megan, you have a copy of mine, so you can send it out if
Yes.
you like. Okay.
Thank you very much. Okay, I don't know if you see in the chat, here's another question. If we refer to child that is in the custody of DHS and they change custody to a foster parent, would they lose eligibility for services with your organization?
So the answer to that question is it depends on where the foster parent resides.
Okay.
If there, again, there's a lot of foster homes in Aurora. Smith Agency is one of the largest providers of therapeutic foster homes for kids with developmental disabilities in the state. They're primarily in Arapahoe County. And so we do support those kids that are in the custody of Denver DHS who live in Aurora. Again, the Smith Agency group homes are a good example of where we have high concentrations of Denver DHS kids that are in the custody of Denver DHS who actually live in Arapahoe County, and we can serve them as long as they're in that geographic border that I showed you earlier. If they reside up in Boulder, if they're up in Longmont, if they're down in Castle Rock, unfortunately, we can't provide 24-hour crisis response to Denver DHS kids that are outside the Denver metro area. We try to use natural boundaries like E470 and C470. And, of course, when you get up to around the Golden Westminster area, we had to, figure out sort of what are the major streets and intersections that we would use as a boundary. But I will include that make sure that it's in the PowerPoint so that if you're questioning, you can kind of see where is that boundary for those kids. How do we advocate for more communities to adopt the START model? Do you have statistics to help show how much money is saved by accessing START services versus emergency services? Wonderful question. Again, our goal has always been for this to be a state program. I think that there are very important entities at the state level, at healthcare policy and finance, the Office of Behavioral Health. I think that also with any state organization that is related to the community-based services that people with IDD receive, they all. I want to say that first of all, we've been in operation for about 1.5 years, which is just long enough to really start to show some of the data that's needed to understand the impact on the community. When you take a look at some of our statistics, and I could show unique graphs and stuff, but that's not the important part. The important part is that 96% of the calls that we have gone out to in the last 1.5 years have resulted in the person remaining in their home. 96%. So only 4% of the crisis calls that we've been on in the last 1.5 years have resulted in either a transport to an emergency department or an inpatient hospitalization. And I have to say that of that, like 4% that did result in transport to a hospital, I think that only 1 or 2 of those instances resulted in an inpatient. But I want to point out that when we go out on a crisis call and we're supporting that individual, and it requires the support of like the STAR program, the co-responder program of police and EMTs. If they transport to the hospital, we follow them. We either ride in the ambulance with them or we drive alongside that ambulance until they get to the hospital, because we want to come inside with the clinical information to say, look, here's the person's symptomology. This is their deviation from baseline. This is our, recommendation as far as whether they need inpatient care. And so those are the types of advocacy with the clinical information that our community is not used to having. And that's why we work with we have these linkage agreements. We're currently working with Denver Health, Children's Hospital, to say, here's who we are. This is what we do. When we show up in your ED department, this is the information that we can provide. And so that's what we're really, those are the kinds of statistics that we're showing. And the other stat that we're showing state entities is the reduction that people are having in the reliance on first responders and crisis services. We're, most of the folks that we are, because when we're doing our assessments, we assess how many times have you accessed emergency services and inpatient care or called 911 in the last, 5 years. And then we start making comparisons to here's how many times they were involved in had crisis situations versus involving first responders and police encounter versus after their involvement and start. And it's a huge reduction. And I'll just be honest with everybody. I'm so transparent about these things. I've been involved in every special task force and work group that the state has ever put together on the issue of mental health and people with IDD. And it obviously the number one thing that we are seeing clearly in our outcomes is the increase in quality of life for people. The caregivers who, again, not only are having a reduction in reliance on emergency services, but we're also working to do things like what are the therapeutic recreation things that this person has not experienced? What are the holistic things? What are the whether it be, like Parks and Rec memberships. I mean, we have got access also to mill levy funds for client expenses where we can, if somebody doesn't have a payer source for any type of therapeutic program, we can provide that funding for the individuals that are involved in our program. So we're looking holistically at like, what are the positive things that we could, when was the last time this person went to the theater? When was the last time that this person went with a group of friends, out to dinner? I mean, we're looking at those things to really enhance a person's quality of life. But here's the other part of it is the bottom line is it's also fiscally responsible. The money that Denver, city of Denver has invested in this program, they will get back, who knows how much, 4 or 5-fold, because it costs a lot of money for Denver to send police and fire out to a situation where they are not going to do any good. And if the person doesn't get the right supports, they're just going to be in that same situation, next week or in just a couple of days. A lot of the individuals that we first started serving when we opened our program were those folks that are called, that are labeled as high utilizers, right? Frequent flyers. Well, we engaged with a lot of those folks that are well known within the system, people who are known on a first name basis at the emergency room, people that, first co-responders with the police know on a first name basis. And I think we did a really good job of engaging those folks. But now, and this is why I'm so happy to be talking with you guys about this, is because what the group that we're trying to engage now are the individuals that are not utilizing emergency services. They're not calling the police. They're not going to the hospital. Instead, they're enduring horrific conditions within their home. Having a dual diagnosis of developmental disability with a co-occurring mental health issue is one of the most isolating experiences that people can have in our community. And so our goal is to, at this point, educate our systems enough to identify those individuals so that we can get in and provide them support. And there's people who have legitimate reasons for fears to being involved in the system. I totally get that. Our goal is not to come in and judge providers. Our goal is not to come in and make value judgments about people's quality of life. Our goal is to come in and help relieve the stress and anxiety around and the stigma around mental health for people with IDD. And again, work against that diagnostic overshadowing that is happening on all aspects of, all around people who are dually diagnosed. And so those are the outcomes. Here's the hard part. It's hard to tell government officials how much money you're saving. Right? It's like dark matter. You can't measure it. Like, how much money are we saving? I don't know how much we're saving in terms of dollars, but what I do know is that 96% of the calls that we go out on did not involve police and fire. And the person remained in their home and had no other utilization of emergency services. How much is that worth? It's absolutely invaluable to the people who are receiving that service, but it's also you know who else is thrilled that there's a Denver START program? The Denver Police Department. They're thrilled that we exist, and we provide training for them, and they provide training for us, and we have a written linkage agreement with the criminal justice services at Wellpower, who support the Denver Police Department. So those are the things that we're trying to constantly go back to the state and say, I served on the Regional Center Task Force back about 2015. Where they were trying to figure out how to close the regional centers because of the cost of them. And my statement was the only way to ethically close the regional centers is by attrition. You have to have community supports for people that are in the regional center to live in the community. And if that doesn't happen in Alamosa, if it doesn't happen in Grand Junction, if it doesn't happen in Fort Collins, if it doesn't happen, in Fort Morgan, then you're never going to have the capacity to support those individuals outside of the regional center. And at $450,000 a year residency for every individual, if that money followed them to the community, you could have START programs in every community in the state of Colorado. So these are the arguments that we're making and have been making for years. Now I'm excited to be able to be able to bring START data to the state and say, well, this is how it's benefiting the people of Denver. We really would like to support Arapahoe County because of the concentrations of START clients that are there. We're excited that Boulder is joining, and that's what we're hoping right now, is for that sort of domino effect within the metro area. But we won't stop providing this type of information to the state to say, there's many states in the country, Tennessee, North Carolina, state of California, Texas, New Hampshire. I can't remember. Those are statewide programs. And so again, this is a model that has evidence support. It's not like an experiment. You know what I mean? Because I feel sometimes that's the thought, is that we don't have the money to experiment. Well, this is evidence-based. Those states are saving money. And the National Center for START Services can show you what kind of impact that they're having in those states. So that's a very long answer to the question, but I appreciate you asking it. I'm sorry, what else did I miss in the chat while I was on my rant? Yeah, any other questions about START or?
So one question that came up, how do we advocate for more communities to adopt the START model? And do you have statistics to help show how much money is saved by accessing START versus emergency services, which I think you may have answered.
Yeah, I mean, again, you can't say this is how much we saved, because again, that's one of those things. It's like, well, since we saved it, we can't count it. But there's no doubt that, again, when you can show that 96% of the calls that we went out on didn't cost the city any money as far as police involvement. The other thing too is it's kind of interesting is that the city of Denver is actually saving the state money. And the reason that how that's happening is that if you all are familiar with the CIS level, which guides the amount of funding and supports that are needed for people to live independently in the community, we are having an impact on people's CIS levels. And it's pretty clear. I think that's one of the things that we have that that's the neat thing about having the support of the National Center for START Services, is they help us take a look at our local community and do the data management to be able to figure out, for example, one of the things I haven't even thought of until this moment is that we can take a look at pre and post CIS levels involving START. So there's outcomes like that I think we have the capability of studying to say, yeah, if we help a person move from a level 6 or level 7 in the regional centers to live in successfully in the community at a level 4, which is pretty typical, or a level 5, well, then you can literally count the dollars that the state saved. Those are the kind of arguments that we're trying to make to the state, to say that it has an impact if you have a city program, but if you have a state program, then it's really saving the state money. So somebody raised their hand. I saw Amy did.
Yes, hi, that was me. Thank you so much, Brian. This has been such a fascinating presentation. And another example, just like Anne's presentation, of how really taking care of people requires such a comprehensive and holistic methodology, and we can't just take it piecemeal. So it's interesting because we've talked about, this is a panel or a presentation, a webinar in caregiver mental health. And it's like, well, guess what? If you want to talk about caregiver mental health, then you've got to talk about the care recipient and how you can support the caregiver in all ways, not just in focusing on mental health support, but in all the ways that the caregiver needs support in taking care of their person.
Yes.
I thought of a couple of intersections that I wanted to, I think we have time to mention briefly. We're on until 11, and Megan, I think, has a few slides that she wanted to share at the end for some additional resources outside of Denver Start and Senior Reach. But there were a couple of things I thought of that there might be intersections with in terms of Denver Start. One is the Colorado Developmental Disabilities Council. And the reason I think of that is because it's a governor appointed body. Every state has a Developmental Disabilities Council. And I'm not sure where the connection can happen with the CDDC. I serve as the agency representative for the Colorado Department of Human Services for aging services. And I just feel like I just wanted to speak that out there, that it seems like there could be some crossover in terms of advocacy for this type of inclusive and holistic approach to mental health, and especially what you talked about with the overshadowing of, just ascribing mental health issues to that person's disability, which is really unacceptable.
Yeah.
I think is what it comes down to. So a lot of what you're talking about is really in line with the mission of the CDDC. So I don't know if maybe we can talk separately about if there's some kind of connection that can be made there, or maybe there's already a connection I don't know about.
I just want to say that right now, I mean, this is the reason that I'm trying to also take every opportunity to speak to groups like yours, because I want to get the word out, first of all, that we exist and we start to engage those individuals that are not utilizing services, that are enduring pretty rough situations in their homes. But yeah, also the whole idea about the linkage agreements is about relationships. It really is how it's happened. I mean, that we did system of cares for people with dual diagnosis in Aurora around those programs at the mental health center, and all of that was based on relationships. So that's my hope, is that today I make these relationships with you all, and that those connections that you have within our disability community is how we make those introductions. We recognize who are the important people that need to be at the table, that need to be a part of our advisory council, and hear about the work that we're doing that hopefully can be accessible to other people in other communities in Colorado. So I think the Colorado Development Disability Council is really important. I think that folks that are at again, offices of behavioral health, who don't have also the CBHC, the Colorado Behavioral Health Council, they don't often have discussions about people with IDD, because they're like, well, it's about, what is that, like 2% of the population? We've got other subpopulations we need to be concerned about. But I think that if they were to take a more objective look at the resources that people with IDD are utilizing from their behavioral health system, and not very well, then they become a part of the conversation too. So I ask anybody who has those kind of linkages to please introduce me, and we would be happy to have more in-depth conversations about what their system has to benefit from programs like START and services like START.
Thank you, Brian. For sure. I think there's some other connections. Anthony suggested is wondering if you're connected with Imagine Colorado, and I'm sure there are others that we'll will kind of come forth from this conversation. So I think that goal is being achieved in at least some way. Another connection that I have been thinking about more with respect to people with developmental disabilities and aging, and in the intersection there, and particularly, and this is where I think Anne comes into with dementia diagnoses. And I don't know how, I realize it's a very new and young program, but I don't know how much experience that you might have with serving a population that has developmental disabilities, but is also showing cognitive impairment. And we're seeing more of this because people with developmental disabilities are living longer, which is great. But of course, the number one risk factor for dementia is age. And so we're also seeing that there's incidences of more dementia diagnoses in this population. And it's another kind of curious, this is very specific, so you don't have to speak to it very long. And if everyone's like, oh God, why'd she ask that specific question? But distinguishing between dementia as a diagnosis or cognitive impairment, mental health, and then the distinguishing from the disability, I think is another area that I'm interested if you've had any kind of interaction with or thoughts about, or if that is anywhere on the radar for Denver Start.
So could you repeat the question one more time? Sorry, I was reading the chat in my brain.
Oh, that's okay. I was just
do both.
wondering how much dementia or cognitive impairment has revealed itself as an issue in the population that you're serving, especially if you're serving people with IDD who are aging.
So the largest group that we're currently serving is transition age youth.
Okay.
That's the largest group. The second largest are adolescents, followed by adults, which are over the age of 23, and then the smallest group are children. So what I would say about that is that we have not encountered yet a lot of folks that are experiencing dementia, and I think that that's a result of people that are in older adults that are living with those conditions in the community have been linked to other resources and are often not labeled as having a mental health diagnosis or issue. So I think that there's a diagnostic overshadowing that, you know, if this person has an intellectual development disability or if they have dementia, that all of these things that they're experiencing are related to the dementia.
Interesting.
And so, you know, our goal, if we have somebody who's referred to us, who is an older adult, for example, they have dementia, what we would do is in our assessment, is in that biopsychosocial assessment, would be to let's understand what supports does this person need around their developmental disability? What are the supports that they need around their dementia or memory loss? What are the things that they need that are holistically related to their overall well-being and mental health? And so our goal is to not just like, well, we don't know what it is, but we know that it requires a lot of supports. Our goal is to go through and say, now what approaches are appropriate? What supports are needed for each one of these conditions that they're experiencing, just like we would if as a result of, we're like, this person is pre-diabetic, you know what I mean? Or this person is also we're recognizing that they may be experiencing hearing loss. Do you see what I mean? So that, like, the START would treat conditions such as dementia as a part of the human condition that we're trying to assess in everybody that we work with. And so there would be no exclusionary criteria around that. But I think that, again, the reason that we're explaining this model is so that people don't go, well, this isn't appropriate for START because they have dementia. That's not where we're coming from. We're coming from the perspective of every single one of us, regardless of what mental health conditions we have, are trying to achieve PERMA and not be in crisis. And I just wanted to respond. I read in the chat, you know, this about mental health not always resulting in violence, and that's absolutely spot on. Is that mental health crisis does not mean violence. Mental health crisis, you know, there are folks that can experience catatonia as a result of severe mental health, where they don't have the capability of caring for themselves in any way because of the seriousness of their mental health situation. So I want to debunk that right away and say that I'm not implying at all that mental health crisis is a result of or related directly to violence. People can be a danger to themselves also. So in the past, when people experienced suicidal ideation, they didn't have very many resources to take that to get support. So no, when we're talking about police encounters, we're talking about funding. We're talking about the city planners and organizers that allocated the money to create a START program. They're interested in dollars, and that is the resources that are used either wisely or not wisely from the funding streams. So I don't know if there's any other questions about that, but yeah, those are great points, and I think that those are things that we advocacy is always a weird thing. You always have to appeal to your audience. And in some cases, it's about quality of life. And in some cases, it's about utilization of resources. They typically go hand in hand.
So another call out for any questions for Anne or Brian? Okay. Well, I'm going to include obviously the presentations in the email. This presentation or session will be uploaded to YouTube, so we can share that as well. Oh, Charlene, okay, I'm curious about something. Can you speak to that, Charlene?
Yeah, please.
Mute. I'm sorry, I guess I tend to type more than I do talk. I was curious, do you guys have any studies about the onset of that psychosis that happens to typical teenagers when they hit like 19 or 20, but it's actually in the demographic of like full care, you know, IDD, ADD children, teenagers?
Yes.
You do?
We do.
My child was, I think that's probably why I got invited to this. I'm not even in Denver, but I've got a kid that had onset psychosis at the age of 19, 20, full all out hospitalized, you know, twice for it at a 2-week, 3-week period. And that's more like what my interest is like, actually, I was left pretty much alone. And it's something I always say to any of these things I get invited to, that there just is no resource for parents who have children who turn from these sweet kids into monsters. And she became really, really bad, and trying to get her on the right meds, I like had no support. There was nobody who wanted to talk about it. Everybody kept telling me they have never heard of such a thing. You know, parents were not talking about it because they were embarrassed that their kids had turned into these. If they were walking, talking normal kids, they would have ended up in jail. That's what I'm talking about. But they don't, because they cannot will themselves onto the street to become problems. You know what I mean? Those are the population and the parents that I personally care about, because I've been through it and I hate to see anybody go through that. So, but I don't even know if they've even done any studies about it, or if there's any. I've looked and looked and looked, and you know, I haven't done any searches, you know, recently. But do you guys have anything about that on, you know, making more people aware that it actually does happen more than anything? And you know, because I think your START crisis or START program sounds more like people who can walk out into the street, you know, and cause a lot of harm to other people, rather than the ones that are basically, you know, not able to do that.
No, I think I just want to address that part, is that when we were talking about addressing funders, that's the funders' perspective, is that they're interested in the people that are asking for police support.
Yeah.
As you know, when you're experiencing a mental health crisis with your loved one, the last thing that you need typically is a cop.
Well,
Because I mean,
but
for
let
safety
me
reasons,
interrupt you for a second,
for
because
managing safety, I understand that, but they haven't committed a crime, which is what our criminal justice system is designed for.
they have committed a crime or they have not.
No, they have not. They're
Okay.
experiencing a mental health. If somebody's having a psychotic break, and they are delusional and hallucinating, they're not committing a crime. Now they have the
Right.
potential to commit a crime if they physically assault somebody in situations like that, but most of that is around not understanding the mental health condition. And so our criminal justice system is designed to support the community in terms of crime. And so they don't have a therapeutic approach. I mean, we're making strides in that we have the STAR program in Denver. Other communities, I know Aurora also has got UC Health, where they have social workers that ride along with police or go out instead of police in mental health situations. And they can contact police if necessary for safety reasons. But gosh, we work so closely with the STAR program at Denver. Like 9 times out of 10, those people that are experiencing serious mental health symptomology don't need a cop.
Yeah, but in my case, when this psychotic break first happened, the police were called because they thought I was abusing her, when in actuality she was ripping me to pieces with her nails and everything before she got the right meds. But all they did was just make sure she wasn't harmed, and then they said, "Oh, we're sorry about you," and then they laughed and left. But that's okay. I mean, I kind of like, okay, kind of joked with them about that, but this was like a long time ago. So, there is some expense if you've got, weird things going on. You've got people who are mandatory reporters who are, doing that kind of thing.
Yep.
But it's like I said, where's the help on that? And it still hasn't happened. I absolutely think your program is great. Don't get me wrong, but there's just so much more to it than just, that.
Yeah.
So Charlene, I don't know where you're located, and it sounds like this happened.
Adams County.
Yeah. So, but in Access Health System actually has a program that started about 3 years ago called Ascent. At first, actually, it was called FEP, First Episode of Psychosis.
Yep.
And it's actually for that purpose, is working with children, somebody 18, 19, early 20s who has their first episode, and they work with the families and the individual. And I know there's support groups but again, that's at Access.
Yes, but those are typical children, correct? Those are typical teenagers, walking, talking, absolutely normal mental health. Everything's normal about them.
So not having a disability.
Right. My child is absolutely disabled. What I was told at the time is that if a child has cerebral palsy and is ADD and IDD, how on earth can they have a psychosis break?
Right.
Mm-hmm. There we go.
Right.
That's what I was told at the time. And this was 5 years ago, which is, I mean, I've seen some things being popped up here and there, hopefully I kind of hope it's because of my complaining to all the committees that it's a population that is not addressed, and it still isn't addressed because it still seems to gear itself toward people that walk and have gone to school and they've had typical lives up until they're 19 years old. She has not had a typical life. She's never had a typical life, So that's what I was saying, how at this point is there a study on that? Because when it happened to me, happened to my child, and we had to deal with this, there was nothing that I could find on it. I even wrote the Mayo Clinic to ask them if they had never got an answer from them, if they knew anything about this, so, and that's like I said, this program, I don't think this program addresses that in particular. You're addressing more along the lines of just crisis, basically, or to prevent the crisis, which prevents the cost, right?
No, that's just when we're talking to funders.
Yeah.
Our goal, and you're absolutely right, Charlene, because I brought up the program that's in Adams County, and I'm also aware of the first case. There's a program at the Aurora Mental Health Center too for people who have experienced early onset of psychosis or first onset of psychosis, and when I was at Aurora Mental Health Center running the program for kids with IDD, and that program was funded for, young people who have experienced their first episode of psychosis, they would not accept our referrals because they said, we don't work with people who have kids that have intellectual development.
Right. Yes, that's what I heard.
No, that's the gap that has been existed for years between the mental health system and the IDD system. And so that is absolutely 100% our mission, is to educate the behavioral health community to understand that, yes, people with intellectual disabilities and autism can experience psychosis. And they do, and that they need the treatments and the supports that are very similar to people without disabilities. And there's some things that maybe we should take into consideration when they do have a disability.
Yeah.
And
which
we're
is
also
why-
trying to teach people, caregivers and parents, as well as IDD service providers, that yes, people do experience psychosis, and these are the systems and advocacy and the education that you have to bring to the behavioral health providers, because they don't know. And it's very frustrating, and but it's 100% tied to our mission, is to educate those people that run programs on first episode of psychosis, to get the fact that people with IDD are in your community, they're experiencing first episodes of psychosis, and they need support. And there's nobody in the IDD system who specializes either in psychosis and understanding what psychosis is and what it looks like and what are the treatments. So that's our goal, is to bridge those, is to make
Well,
sure.
if you ever need help on that particular subject, I am very much a kind of an expert of having dealt with that in the situation and, everything. It's made me not exactly the nicest person in the world in the past 5 years, because I don't have patience for anything, because everything concentrates on her. So, but I guess mainly that's what I also wonder, if there isn't any education and, help for parents who are just starting to deal with this. Because I can tell you that when Lena was over at the Children's Hospital, they were doing their best to get her put into a group home, which costs more than her just being home with me.
Right.
And I'm a lot more patient with my child, than I think anybody else would be, considering, the things that she comes up with. So I don't know. And also, by the way, Adams County, they did nothing for her. They couldn't deal with her. In fact, what you just said, we don't think that can happen. I don't know if we know how to deal with her. The only thing they were doing is a nurse on a TV looking at her and trying to ask her questions. And of course, she's not going to answer those questions because nobody wants to talk to a TV. And except, well, she does, but that's a whole other psychosis right there. But anyways, but she actually goes to Jefferson County now and sees a psychiatrist every 3 to 4 months, who checks in, makes sure that she's doing okay, the meds are working, kind of thing. But it took hell to get a referral there. And she was in a deep psychosis to get a referral to Jefferson. And they seem to have more of a grip of how to deal with people like her than most of the other counties and, mental health centers do that are county based. So that's my concern. I just think we need more education for parents, saying it can happen, be prepared, and here's where you need to go, and here's some support, because you are going to go through hell too, just like your kid. Do you see what I mean? Is that part of the START program? Sorry.
Yeah.
I tend to get militant about the mental health issues, because it's just something that was so lacking, and it's so slow getting anything going, No,
Charlene, I've got almost 30 years of hearing parents' stories that are very, very similar. Years of it. But I think Tracy had a question. Tracy had her hand up. Sorry.
I guess maybe not. I didn't see anything in the chat from her. Well,
it was my cursor that looks like a hand.
Right.
So that's
okay.
So Tracy did not have her hand up. I had my cursor on Tracy that looked like. Okay, sorry about that.
Yeah, so we just have a few minutes left. I thank you everyone for your questions and for sharing. And so specifically to Brian and Anne for coming and helping us today. This was so wonderful and informative, and I hope that everyone got something out of it. I will send a follow-up email. I just want to briefly say we're working with Bell Policy Center to distribute a survey about unpaid caregiving in Colorado. So I will include that also in the email. And then I did kind of make a slight list of mental health resources that are kind of low cost or free of charge. It's going to be in the slides that we send out. But if anyone has more suggestions or, that please let me know and I can just add it to that list and I think we're good. So, anything else, Amy? Do you have anything?
I think for me, I think this was a great presentation. Thanks for everyone who stuck around to the end. And it is, these presentations are recorded and they'll be also available on our website if anybody else ever wanted to check out the YouTube video. We have the YouTube page where we post these videos as well. And if there's any ideas for future topics for statewide webinars for information affecting caregivers or respite, then we're also very open to hearing more about that. I think that's about it. It's 10:59, so we're out of time.
I do notice that we can't, I'm not capable of putting files in the chat. So I'll email them to you.
Great. Thank you. Yes, that would be wonderful. That'd be wonderful.
Thank you very much.
Thanks,
right.
everybody.
Thanks so much, everyone. Have a great rest of your day.
You too.
Thank you.